Hi, this is John Kanellopoulos here from our office in Greece, Athens, Greece. It's great to share with you some of the highlights of taking care of a patient with the Athens protocol. Let's start with the images on the left eye of this gentleman who is past 40. So usually at an age that we expect keratoconus to be stable, we can see the cone here, thinnest cornea at 468, just by looking at the epithelial maps on this patient late last year in 2020, we can see that the cone is active. He's complaining of deterioration in his vision, change in his refraction. Let's go look some more images. This is his cone. Many people would call this claw-like and pellucid marginal, but we saw here, this is definitely not pellucid. This is a oblique infratemporal cone in the left eye. These are now his sequential pentacams. From 2015, 2017, 2020, and January of 2021. And we can see that there's a progression of the cone, a certain jump from the past of 1 diopter, as we can see here. And this, along with the epithelial maps being activated for us, is a significant enough reason for him to undergo the Athens protocol. These are the numbers with the ray tracing software Innovize that we have for the first time globally used, and it's currently in print in the Journal of Cornea to treat in conjunction with CXL for an enhanced Athens protocol using ray tracing. We can see here that the beauty with the Innovize software is that despite it trying to fix the cornea curvature, with lasering the surface of the cornea, it takes into account the significant coma the posterior cornea curvature establishes as well. And another caveat with the ray tracing software is that it deals in a keratoconic patient as if the cornea is tilted, since the ectasia is infratemporally is tilted. So it treats most of the irregularity as tilt and not necessarily as removing the bump on the cornea. 2 weeks out, and there's still a persistent epithelial defect, and this is mainly the reason I'm showing this video. We will see a short video on how we dealt with this. 2 weeks down the line, we can see necrotic epithelium hyped up around the borders of this epithelial defect. We have a bandage contact lens. We stopped using corticosteroids. He's just on moxifloxacin. Still, for a week, it's persisting. So what we're gonna do here is we're gonna take a step back in order to take 2 steps forward. We're gonna enlarge this epithelial defect, remove all this necrotic epithelium, and give the chance to the cornea surface to resurface faster. And so here we are on the slit lamp. We can see the epithelial defect stained with fluorescein, and we're gonna use, of course, under topical anesthesia, we're gonna use a Q-tip soaked with moxifloxacin. We see how easily the epithelium is removed just brushing the Q-tip around. So I'm going to remove all the necrotic epithelium and enlarge this epithelial defect almost 2-3 times larger than it is. We can still see the stained stroma from the fluorescein and how much I've enlarged the epithelial defect, making a step backwards in the healing to make too fast moves, too fast steps forward, because now with the bandage lens, abstained for steroids for a couple of days, I'm using my toothless forceps here to clean up the edges of the epithelium and allow a faster epithelialization. So the treatment was vitamin C, moxifloxacin 3 times a day, bandage contact lens, oral doxycycline twice a day, 100 milligrams to reduce proteolysis and enhance improvement of the surface, and autologous humerus drops 2-3 times a day. So we did this February 4th. Today is February 8th. We are 3 days later, and we're going to see in a few seconds how the epithelium is healed completely, despite the fact that it did delay us in the epithelialization for several days. So we saw in the video that we removed the hyped up necrotic epithelium back in Thursday, February 4th, and today is the 8th, and we see complete epithelialization His vision is bumped up to 20/30 uncorrected. It's going to get much more since we just removed the bandage contact lens, and the eyelid will really polish the surface. We'll get a much better surface. We'll reinstate, of course, topical corticosteroids, stop the moxifloxacin. He's in full activity, besides protection from UV light and also additional vitamin C in order to avoid any haze induced by the laser ablation and the also CXL that will affect that long term. Hope you found this interesting. This is John Canalopoulos signing out.